Welcome to the third training in the Domestic Violence Healthcare Toolkit. The Healthcare Toolkit is a project of Nextdoor Solutions to Domestic Violence in partnership with Mayview Community Clinic, with funding and support from Blue Shield Against Violence and Futures Without Violence. In this training, domestic violence screening, safety planning, and mandated reporting, how to assess patients for intimate partner violence, we will cover the logistics of screening, how to address both positive and negative screens, safety planning, mandated reporting, and cultural considerations. So let's talk about what the domestic violence screening is in the first place. Screening or assessing patients for domestic violence is a required part of the Affordable Care Act. While the specific questions in the screening may vary, there's usually 3 questions asking about a patient's experience with physical or emotional abuse during the last 12 months. These screenings set the stage for either an intervention or an educational opportunity to discuss healthy relationships with the patient. Next, let's look at when an assessment should happen. Each clinic will need to determine where in their workflow the assessment works to best serve their patients. Ideally, the screening would happen early in the appointment so that a positive screen could inform the rest of the visit. Some clinics have medical assistants conduct the screen before the physician does their own exam. That way, if the screen is positive, the medical assistants can alert the physician, prepare referrals, or contact a domestic violence advocate while the patient meets with their doctor. One of the biggest questions is, exactly who should I be screening? At a minimum, providers should screen all adolescent and adult women. A provider should screen at every visit. A patient's safety at home can change between appointments, and sometimes patients don't feel comfortable disclosing on a first visit. Keeping the lines of communication open maximizes our ability to help. And because we know domestic violence impacts men as well, screening should be expanded to include as many patients as possible. Now let's look at the actual screening process. The screening may look like a quiz, but it's really more of a conversation. Start with a friendly, straightforward opening like, "How are things going at home?" Then you can frame the screen with a statement of concern, such as, "We see so many patients that have been affected by domestic violence. We've started asking these questions of all of our patients." Or, "This might not be an issue for you, but some of my patients have experienced violence in the home and are afraid to bring it up. So now I ask everyone." Then ask the questions. Here are some sample questions. Within the last year or since becoming pregnant, have you been hit, slapped, kicked, or otherwise physically hurt by someone? Are you in a relationship with someone who threatens or physically hurts you? Has anyone forced you to engage in sexual activities that have made you feel uncomfortable? Based on a patient's answers and your instincts, you can ask follow-up questions as needed to help you and the patient determine next steps. What happens if the screening is negative? Our job is not over just because a patient says no to the screening questions. In fact, this provides a great opportunity to provide education on healthy relationships and where someone who might be experiencing domestic violence can get help. You may want to give your patients a card or a brochure with healthy relationship information that they can take with them. One of the biggest fears providers have voiced is the concern over what to do if the patient screens positive for domestic violence. Each clinic will have its own set of protocols for addressing a positive screen, and if you don't have one, we have a template for you on the Toolkit website. At a minimum, a provider should ask empathetic and non-judgmental follow-up questions to better understand the nature of the abuse and how the patient wants to proceed. Inform the physician if they were not present during the screen. Put the patient in touch with your on-site domestic violence advocate, or, if your clinic does not have one, link the patient to a local domestic violence service provider. And if there are reports or forms specific to your clinic, be sure to complete those as well. Most screenings are conducted either verbally or using a printed form. Let's talk about the difference. A written screening is faster and easier for most people, especially in a busy clinic to administer. Some clinicians feel it's less awkward. The drawback is that a written screen does not easily lend itself to follow-up questions, and it's hard to develop trust and rapport that you need to work with victims and survivors when all you have is a sheet of paper. Other people feel that this approach is just too cold or clinical. Verbal screenings, on the other hand, are slower. They can be harder to administer, especially if you're working with a patient who speaks a different language. It can feel awkward or even intimidating to ask patients these questions, but it's also easier to smoothly segue into follow-up questions, build rapport, and develop a trusting relationship. Asking the questions verbally allows providers to easily transition into healthy relationship education. We recommend that even if your clinic uses a written screen, that you also ask the questions verbally. Most jurisdictions have very clear guidelines on mandated reporting, and it's critical that providers follow the law and their clinic's reporting requirements. However, we caution providers to bear in mind that sometimes reporting can cause additional problems and further victimize patients. So we encourage a trauma-informed approach to reporting. First, exercise transparency whenever possible and approach the issue from a strengths-based perspective. Let patients know about the clinician's duty to report. Ask the patient to be present while you call in the report. For some patients, being present and participating can be empowering. Directly involve the patient wherever possible. Advocate for the patient with the authorities. For example, you could say, "As a mandated reporter, I have to make a report, but you are welcome to sit with me while I call this in, so you can know what's being said and that there are no surprises. I can also put in the report any concerns you have about what will happen when your partner finds out about the report." Safety planning is an important part of any domestic violence protocol. Safety planning can be a simple short-term strategy or a more complex and long-term approach, depending on the needs and the wishes of the patient. What is important is that they leave your office with next steps and know where they can get additional help. Safety planning may include making an appointment to speak with a domestic violence counselor or keeping a hotline number somewhere safe, packing a go bag with important papers, cash, and clothing should the patient need to flee quickly, filing a police report, or making a follow-up appointment with her provider. Even with a negative screen, there's still plenty providers can do to help patients stay safe. This includes providing healthy relationship education at each appointment. Healthy relationship education is important because it provides information and resources to patients who may not have disclosed abuse, but could be open to a more indirect approach. It empowers patients to know the signs of a potentially abusive relationship and take proactive steps to stay safe. And it educates patients about domestic violence, and they may in turn help a friend or a family member seek services. Lastly, we want to acknowledge that there are always cultural considerations when providing services. Domestic violence happens in all cultures. However, how domestic violence is understood and addressed varies. It is most helpful to understand a patient's culture and belief system and to exercise sensitivity to the patient's beliefs and actions, understanding them from a cultural context. Whenever possible, try to work from the patient's cultural context in a supportive and non-judgmental way. We need to be careful to avoid using language that puts down a patient's culture or that could put the patient on the defense. This concludes this training on screening, safety planning, and mandated reporting. We have covered the logistics of conducting a screen, next step for providers, and we've talked about what goes into safety planning and how to manage mandated reporting requirements in a way that supports victims and survivors. If you have any questions or feedback, please email us at dvhealth@nextdoor.org. On behalf of Nextdoor Solutions to Domestic Violence, thank you for viewing this presentation.